Welcome everybody to this webinar that is an organization of the EURO-NMD European Reference Network for Neuromuscular Disorders in collaboration with the European Reference Network for Rare Neurological Disorders and the European Academy of Neurology. Today's webinar is going to be presented by Dr. Reimann, and it will be about cognitive symptoms in myopathies. Dr. Jens Reimann is a consultant neurologist at the University Hospital Bonn in Germany, where he did his training as well, and he runs the department's muscle lab, muscle research and myopathology unit that he inherited from Professor Felix Jerusalem. He founded it in 1981. He also supervises the clinical neurophysiology unit and the neuromuscular outpatient clinic of the section of neuromuscular diseases that is currently headed by Professor Cornelia Kornblum. He has very different interests, as you can understand from what I have already said, and he describes that his motto is, if it concerns skeletal muscle, he's interested. So besides the histopathology, he has an interest in basic mechanisms of muscle damage, denervation and repair, and interaction and overlap of pathomechanisms are something that interesting him particularly, namely, for instance, structural with metabolic or inflammatory alterations with degenerative processes. He also has the kindness of presenting today's webinar about the cognitive symptoms in myopathies that I think that everybody knows that is a growing field where much is learned as we speak on a constant rate. And so welcome, Jens. The floor is yours, and don't forget to unmute yourself, please.
Yep, should work. Do you hear me?
Yes, perfectly.
Should I keep the video going? Is it any use?
Yeah, you can now present your presentation.
Right.
Okay.
Good. So yeah, this is today's topics. I've got a few disclosures, not particularly important to this, although there's an advisory board missing, but not a firm. And so we get to the core of the problem, cognition. What is cognition overall? And mostly people talk about cognition, they think this is about thinking. And thinking is part of cognition, but it's not all. It's actually knowing and looking at things and remembering things, not abstract thought, that are probably what we mostly do in cognition every day. And these are obviously complex things. And it used to be that cognition was pretty hardly defined by the brain regions that we thought were majorly involved, which is, of course, incredibly important. But we learned that from patients with lesions, and we now think in networks mostly. So this is a bit old-fashioned. And the other very important point, possibly the most important point, is that research points to the fact that while we might not be born with a clean slate, this is still a philosophical debate, but we learn this from the outside. So it's the interaction with the environment, in particular with other humans in a certain context, that gives us our cognitive abilities that we acquire. And those things have been grouped in so-called cognitive domains. And for a while, it was pretty freestylish. So everybody had his or her cognitive domains. And so these days, these are the ones that are from the DSM-5. So they are listed there under the cognitive impairments. And that's the reason that almost everybody, at least in psychiatry, uses them these days. There's a bit of a drawback hidden here. So these aren't exclusive categories. And they are also a bit hierarchical, but not totally hierarchical. So there are some functions that are usually referred to as higher functions, like social cognition or executive function. but that doesn't really mean that everything else is just, the basic, the groundwork. And if you look at these building blocks in their slightly precocious assortment, you find this down here, perceptual motor function. And this is a bit I'm slightly unhappy with, because it used to be two domains. One was sensory perception and the other was motor function. And obviously, if you look at muscle patients, it's important that we have the motor thing in a separate. But this is the way it's now. And the other thing is that when we go to testing, and of course that's the way you go about if you want to know things about cognitive symptoms in your patients or in anyone, it's not always entirely clear which author believes which test to be in what domain. So, for example, in complex attention and executive function, you've got the control of attention, and the control of attention somewhere goes into executive function, but where this line really is, you find different ideas about this, and that could lead to the fact that you find a test in one paper saying the patient's got attention disorder, and you find another paper saying, well, they got executive function problems, which is a bit of a problem. So I already gone into this. How do you examine cognition? You choose tests. You choose tests to test a skill, and then you try to control for anything that might have an influence, confounders, on the performance of that skill, or what you measure as the performance of that skill. And obviously, in certain patient groups, and muscle patients are a difficult lot for this, you will have to include other effects like impaired mobility. So if you want to have a test where people have to go gross movements, it's going to be rather impossible if they got severe myopathy. Limited eye movements. Just think about somebody with CPO sitting in front of a monitor and looking after things in a certain way. It's not going to work. He's going to move his head back and forth, and the control person is not going to do this, and so on. And the scientific way of coming up with a result from this is to have a control group that is as closely matched to your population as you can. And well, basically for anything, but in particular, obviously, for things that have an influence on cognition, age, education. And so then you can see whether you find a difference. There are two drawbacks in this. First one is, obviously, it's almost impossible to find a complete, healthy, matched population for somebody with a severe myopathy, because somebody with a severe myopathy is going to be impaired in his muscle function, and you can't have a healthy person with the same impairment. So you have to select things where this is not going to be a major problem, as I have said before. And the other thing is that for many of those tests, there are normal ranges. And you will come upon things, tests, papers, reports, where people show statistically significant differences between the control group and the experimental group, but they're always in the normal range. So this is formally not an abnormal result, although you have shown that there is a relevant difference. And actually, this is a finding that we see in a number of rather frequent myopathies, and it's making things a bit difficult for us. So why would you do this? I mean, you're busy doing muscle research, muscle clinics. Why would you start going on to cognition? And the thing is that cognition, obviously, as it is the interaction with the outside, you do cognition and the patient does cognition when you do anamnesis, when he tells you about his complaints, when he tells you about whether your therapy is working or not. So if you want to have an understanding what this patient is trying to tell you and what you can find, you will have to have an idea whether there is a problem in cognition. And then obviously there are some things that don't work in everyday life of the patients, and you can't really make out what's the problem. It's you can't find anything in a neurological exam that explains why this isn't going on. Oh, maybe it's a cognitive problem. Actually, I would say it's rather likely to be a cognitive problem if you've got a patient with myopathy, because they aren't that rare. And so you can understand what's actually going on with this patient and what his needs are. And obviously the final thing that we all reach for if we do diagnostics is we want to have a treatment. And we're not very far with this in cognition, but anyway. And before we go into the diseases, we go to the hopefully normal crowd, which is us, it's you. We have to look at our cognition in the interaction with those patients. And there are two examples that I'm always struck with in muscle diseases. That if you've got an FSHD patient sitting opposite to you, and they're not smiling because they don't lift the edges of their mouth, they've got a horizontal smile frequently. And this gives you the idea that you're not interacting well, because that's how we brought up. You look each other in the eye, you smile, say, hello, yes, doc, I'm listening. And even worse, the people with the myotonic dystrophies, who always seem, sleepy and disinterested, sitting in front of you. And you think, yeah, I'm not getting through to this patient. I'm not really sure whether he's interested at all. Well, he is. It's just not working. He's not having a social cognition, interacting with your social cognition properly. And strikingly, the famous description of Kirschmann's of the myotonic dystrophy type 1 was Jammergestalt, lamentable figure. So he actually fell for this. He say, oh, these patients are looking awful, which is not a nice way to say it, although it's a pretty good diagnostic marker, I have to say. And so how do we get from myopathy to cognition? It's most cases pretty straightforward. So we know there's brain pathology in a number of neuromuscular conditions, muscle conditions, and obviously if the brain ain't working, there could be something going on with cognition. And so we have a list of, or I have a list of diseases by now that show these problems, and we're pretty sure that this is a CNS thing for various reasons. And it can be frequent in a myopathy. And the classical examples is Duchenne or the dystrophinopathies, myotonic dystrophies, and the mitochondrial myopathies, where frequently what happens in everyday life is as much or even more determined by the patient's cognitive impairment as by their muscle problems. And then there are diseases that you all see pretty regularly, like FSHD1 or OPMD, where you don't really think that this is a typical cognitive disease group, but there are some parts that have been reported with actually pretty convincing data that there is something going on. And then there's other groups where you've got individual cases, and sometimes it's quite clear that this is a disease that occasionally affects the CNS. So yeah, well, it could be. Sometimes you just can't match them, and you wonder whether it's a double trouble. It's just a cognitive impairment in a patient with myopathy. And so this is a list that's not complete list that I'm currently heading for, and so these are the ones I'm going to touch on briefly, and we're not going to go into terrific detail here. But I think they teach us a bit about how we discover these things and how they appear in our clinical practice. So let's start with the dystrophinopathies. And Duchenne himself already thought that intellect wasn't okay in the Duchenne boys. And this is 1868, I think. About 100 years later, people had autopsy cases, and they weighted the brains, and they said, "Oops, those brains aren't normal. They're light." So this is the first time that a muscle dystrophy was kindly put down as a structural CNS problem, as far as I know. And we know now, and hasn't changed too much from Duchenne really, that about a third of the DMD boys have an IQ below 70, and having an IQ below 70 is pretty low and is an impairment. And we've also seen people with DMD mutations that have an intellectual disability without a straight muscular dystrophy. So it is an isolated phenotype, although they do have high CKs. And we also know that there are some forms of dystrophin. I'm going to go into this in a moment, and particularly the DP140 and the DP71 that seem to be particularly interesting for the brain phenotype of DMD. Now, this marked slide reminds me to say something about intellectual disability. Intellectual disability is the term the WHO now prefers for the formal mental retardation. And it's defined as having an IQ below 70, onset below 18 years of age, and impairment of at least 2 adaptive functions. And again, we've got a problem with muscle diseases because adaptive functions are defined as the functions that you need to have an independent life. And obviously there are motor skills in there. So it's dressing yourself, washing yourself, interacting with other people, and so on. And so it's really hard for people with a severe muscle disease to have a IQ below 70 and not have intellectual disability. Having said that, it's pretty hard for everybody else as well because 70 isn't too high. Mind you, there are smart Duchenne boys. And if you're an adult neurologist, as I am, and you see them in adult age with severe disability, and you have to dial down mom a bit because she's talking all the time and arranging everything because she's been doing this for possibly decades, and you don't really find out whether the guy in the wheelchair is on board with this or not, and sometimes you have to look into this, and I've terribly misjudged Duchenne patients, so seeing people where I thought after 5 minutes they're not even understanding what we're talking about, and it turned out that they're working independently. So you have to be careful there. To the dystrophin isoforms. So the DMD gene is the largest known gene, and it's been around for forever, and it's a really peculiar gene. And what it has, it's got 7 promoter regions. So you get 7 dystrophin isoforms without even starting to splice, right? And these 7 are listed here. And the idea is, so this is the entire stretch. And then you're going down to the C-terminal end of the protein. So you get shorter dystrophin isoforms. And they, of course, there are splice variants. And these days, we are mostly using these abbreviations because they got funny names. And most of those names aren't exactly very well thought out. So retinal is probably okay. Swan cell, well, and ubiquitous is ubiquitous except for mostly skeletal muscles. So it's really not that useful. Stick with those, and you know what's going on. And so you see cortical here, Purkinje cell here. Retina is a bit of central nervous system as well. You see central nervous system here. You've got a nerve here, and you've got ubiquitous there. So actually, everything in the brain should be run by dystrophin. But it is the facts are pointing to DP 140 and DP 71 and its splice variant DP 40 to be very important in this brain problem. And we've got detailed data published or going on to be published. This was a poster last fall on the WMS. And so this is a neurodevelopmental problem in the brain caused by disturbance of dystrophin isoforms. And in particular, DP140 seems to have a neurodevelopmental role. And so this is extremely important because you can skip all the exons you want, and you can put in all the mini and micro and nanodystrophins you want. This is done by the time you've got the patient sitting in front of you. So he's got a neurodevelopmental damage. You're not going to do anything about this with gene therapy or in the grown-up or in the infantile patient. And this is one of the forms that we see, CNS and obviously cognitive problems in myopathies. And the less dramatic form is the Becker-Keener muscular dystrophy. And indeed, their IQ is usually normal, although it tends to be in the lower range of the normal field, although not in every kind. And they tend to be more in the range of learning difficulties and psychiatric problems, behavioral problems. And again, you can be fooled so dramatically. So I got a handful of intermediate type guys here between Duchenne and Becker. They're really smart. They're working in IT or engineering or something. And sometimes they do things. 2 of them are clearly obsessive compulsive. And I've never, I attributed this as a secondary phenomenon to their disability, but actually it's a primary phenomenon of their brain to having some lacking some dystrophin isoforms. And again, there is brain atrophy, and brain atrophy doesn't correlate particularly well to neurodevelopmental things. I mean, if the brain's very atrophic, obviously it's not good, but you can't weight the brain and say, so the IQ wars. And then there's got the carriers, the affected moms. And there's extremely little data on these folks. There seem to be some children, so teenage girls that have cognitive problems. But then again, if you're an affected carrier and you manifest in teenage, then you're pretty severely affected. So I'm not sure this is representative. And just, there's always these funny quotes down here. And there's many of them. But I really have to point out this paper by Dimici, because what they did is they compared mothers of Duchenne children having the mutation and those not having the mutation, where the boy had a de novo mutation, and they compared them to healthy controls. And this is what I said about testing. So they were, both of the Duchenne mothers groups were severely impaired compared to healthy controls. But if you compared the carriers to the non-carriers, there was almost no difference anymore. So this is secondary effect. You've got a very sick boy at home. You've been doing this for years. You're not sleeping well. Your cognition is not going to be as good as a healthy person of the same age whose boy is just normal. And so it's really interesting paper. Going on to the myotonic dystrophies. Now, the myotonic dystrophies are the poster child of cognitive research in myopathies. And we've got plenty of studies, and we got plenty of brain images, and we know about tauopathy, and there's some other theories as well. And we also got social data to back up that this has severe consequences for the patients. So myotonic dystrophy patients, particularly by myotonic dystrophy type 1 patients, are impaired in their life due to cognitive problems. And you can read a number of reviews. I'm just going to point out this, as far as I know, this is the only myopathy we will get detailed data on problems in social cognition. And this is in particular a theory of mind in the type 1s, and reading facial expression and reading body posture. And so in particularly anger, disgust, and fear, which I haven't put down here in the emojis, they are misinterpreted by DM1 patients. And this is the only group of people where we have successful implementation of therapies doing something about the consequences of these cognitive problems. So this is really the spearhead of going into this. So I'm going to drop all this and show this awful table, which really is extremely route, and this is why there's no quote underneath. So I'm not gonna blame anybody for doing this. The congenital myotonic dystrophy type 1, they're actually their own disease. They're much more severely affected, and they usually got global intellectual disability. And if you've got somebody with intellectual disability, I didn't say this earlier, it's really hard to test them detailed for various domains. So you're not getting good data there. But we also see further problems like autism spectrum disorder in these patients with a high frequency. The childhoods are a bit better. Then the adults, the adult DM1 and the adult DM2. Usually the myotonic dystrophy type 2 seems to be a bit milder disease, and that comes through in many of those cognitive assessments. And this is one of the places where you have statistically significant differences to normal populations, but we are still within the normal range. And so it's a bit interesting. But you also get tests where the DM1 is better than the DM2, maybe by the particular crowd that has been tested or whatever. So executive dysfunction, mental slowings, and social cognitions are the things that we see regularly over all the three groups, and that affect these people daily, but it's far from all. Going to the mitochondrial myopathies, now this is an even larger group, and it gets even more problematic. If you see them in the clinic as an adult neurologist, then you probably have things to do about epilepsy, stroke-like episodes, and not too infrequently psychotic symptoms, sometimes severe psychotic symptoms. But they do have abnormal cognition at a high rate. And this is a disease, particularly in the adult manifestations, that often leads to dementia. Some of the studies give dementia rates of up to 90% in mitochondrial diseases. And this is not the severe children where you've got clear-cut structural brain abnormalities on the MRI. So this is really something that you have to look out for, and that will be a problem in the care for the patients. And then it gets really hard to compare these because frequently, we've got metabolic measurements, we've got genotypes, we've got phenotypes, and some of them are frequent and most of them are not, so they're really hard to compare. We've got some data that the classic Milos patient is faring worse than the classic MERV patient, but the classic MERV patient gets sick later in life than the classic Milos patient. So who knows, if you go from the first day of symptoms and test them after the same length, maybe it's the same. But then again, stroke-like episodes and epilepsy or seizure activity is a negative predictor of this in most studies. And the large scale single mtDNA deletion, so your classical CPO, they seem to be a bit better than the mtDNA point mutations overall, but this is really hard to grasp. And thus, we've got only two domains, visual construction and attention, where everybody kind of agrees on that this is disturbed in mitochondrial myopathies. And for everything else, like executive function, verbal fluency is named pretty frequently, but there are studies that say, no, there's nothing going on there. Terribly difficult. Reminder, dementia. So this is the other way. This is not neurodevelopmental. This is going the other way. From a normal CNS function declining. And sometimes you've got conditions where you see both, but we have to look out for both, clearly both in our patients, particularly in the adult muscle patients. Coming to another large group, this is the alpha-dystroglycan interactions. Now, alpha-dystroglycan interacts with laminin, it's laminin alpha-2 in the muscle, but there's various laminins in the brain, and they do various interactions, and these seem to lead to various symptoms. So this is the part where we have to talk about the fact that not only the brain weight, but also some other figures don't necessarily correlate with what you see as symptoms. So you got the neuronal migration pathway as one function, you've got the aquaporin channels as another function, and then you got synaptic plasticity. And you could imagine, or you're pretty sure by animal models, that they lead to different changes in brain. And the classical example of things going different ways are the people with the myopathy, so the laminin alpha-2 mutants. These frequently have these white matter lesions that you see on the side of this MRI. And this is supposed to be the effect of the water content change due to the changes in the aquaporin 4 channels. But this does not relate to the other neurological symptoms. So you've got 10% that show other CNS findings despite having an abnormal MRI. It's really useful MRI if you got somebody with pretty high CK and this MRI. You can go for sequencing of LAMA2 immediately, but it can mislead you in judging the patient's abilities. And for the large group of alpha-dystroglycanopathies, the OMIM has got a pretty smart idea of sorting these difficult diseases. So they've got three categories, A, B, C, and A is congenital muscular dystrophy with brain and eye involvement. And so think Walker-Warburg, think muscular brain disease, think Fukuyama muscular dystrophy. So these people usually have intellectual impairment. You're not going to get detailed testing from them. Then you've got the congenitals with a bit of CNS problems. And this, of course, is not very nice to have severe plus minus intellectual disability, because if it's not severe, it's not intellectual disability by definition, but one can understand what they mean. And you've got the limb-girdle muscular phenotypes where you usually think they only got their muscle dystrophy, but you find data as well on cognitive problems in these folks. And it does, in those cases where you've got enough cases to compare, like FKRP dependent, it doesn't really go with a particular mutation either. So it's really tricky, and it goes more or less with MRI findings. It's a thorny issue. Oculopharyngeal muscular dystrophy. So this is actually, it's kind of surprising. You know, it's a polyalanine disease, and we know there are polyalanine depositions in neuronal cells, and we should have expected there to be something, but everybody was rather surprised when in patients with the rare severe homozygous type, they found problems. This is one of those old cognitive descriptions, prefrontal subcortical circuits. So you'd think this is probably executive function. And then they started looking at the heterozygotes, the more frequent variants, and they started to find things as well. Unfortunately, the largest paper we have, they used a questionnaire on a proxy to see whether they would fit the definition of behavioral type frontotemporal dementia, which they did to a certain extent. But this is more psychiatric than cognitive, than pure cognitive measurement. So yes, we're not entirely sure how much of cognitive problem we see in regular run-of-the-mill heterozygous OPMD, but it's the same story. You know, thinking back about my encounters with OPMD patients, there were a number of folks where I said, oh yes, I think I missed this, and this is the reason why we didn't communicate very well. FSHD, even more striking. It's been known forever, actually before we knew the genetic background of FSHD, that there are early onset severe cases that have problems with intellectual disability, with epilepsy. There's a number of reports about MRI findings, again, white matter changes not correlating particularly well to that. And those were people with remaining repeats like 2, so really small fragments remaining there. But now people are looking at other FSHD populations. And so one study says if you've got a fragment below 24 kb, then you're more likely to have a cognitive problem. And there's another study that actually says they've got 60% abnormal cognitive testing in a case control design. But as we've already mentioned, case control design can be misleading. You still have to use the norms. And they didn't do the fragment size, so we're not in the clear there. But if it was true, we'd be missing an enormous amount of cognitive problems. And you know, for FSHD2, the literature says they're clinically indistinguishable. That might be the case. I haven't seen too many of those people, but I'm not aware of cognitive data. And if you've got those people or you got those data, it'd be really nice to know and see if there is something going on. Now, this seems to be an obvious one, inclusion body myopathy with Page disease of Bonn and or frontotemporal dementia, because if you've got frontotemporal dementia, obviously you've got dementia, and that's going to have an impact on your cognition. Please note that dementia is the rarest symptom in the combination. And the myopathy is the 90%. So it's really likely that you, as a neuromuscular person, are going to see these people first. And then you have to dig in there. And the other problem that I have experienced again and again, although it's not a frequent disease, is that they've got this dominant inheritance, and they believe that their course of disease is going to be the same as the fathers or the mothers or the brothers or whoever was affected first. And I've had people neglecting their therapy, saying, you know, I'm going to be demented anyway in a couple of years. Saying, no, you're actually more likely not to be demented in a couple of years than to have this problem. Please stick to your therapies. And so this is a great problem, and I know a number of those people who have high performance jobs, and obviously going to them and saying, you know, you're going to get dementia would be entirely wrong. But you also you can't lie. You can't say it's in the name of the disease, but never mind. So if if a person with about 40 with you know, scapular winging, it doesn't look like FSHD comes to me, I always get a bit nervous and think, oh God, it's going to be one of those talks. It's kind of vice versa in the neuroacanthocytosis disorders. So McLeod's disease or McLeod's syndrome and the chorioacanthocytosis, they are more famous as cognitive disease, as neurodegenerative diseases, but they do have high CK frequently. And you can find abnormal, if you scan the muscles, if you examine the patients, you're going to find abnormalities. And so sometimes they will come across as myopathies. And they got memory and executive function problems pretty frequently. And whether their dementia resembles frontotemporal dementia or whether it is a frontotemporal dementia, I'll leave to the people who know about neurodegenerative diseases. Not going to wade into that. But that's where it ends up, in particular in the chorioacanthocytosis people. And as they've got early psychiatric symptoms, and so particularly chorioacanthocytosis patients often have severe speech disorders. They're not easy to test, so don't wait. What is interesting, however, is in the McLeod syndrome, which is X-chromosomal disease, there is some data about female carriers and cognitive impairment. So this is always it's a rare disease, and we're still trying to figure out its form. So again, if you got patients, look at them and extensively and try to figure out what's going on there. Is this epilepsy? Is this psychiatric? Is this something else? And with that, we come to the point where we got to talk about those individual cases, and I didn't list them again here. And obviously, there are diseases where you've got brain affection, and of course that could cause cognitive symptoms. But then you've got other diseases where you can't really make up a working connection between having the metabolic disturbance or whatsoever and having a brain phenotype. And if you look through those papers, it's amazing. Most of those patients are male. Now, males and cognitive disability go with one another. It's just the X chromosome. So they got to be careful there. Then they frequently got psychiatric comorbidities. Fair enough. I've just gone through a list of diseases with the same combination and where we're pretty sure that this is something. But again, if you've got somebody who's been schizophrenic for 30 years and you do cognitive testing, are you really going to find a cognitive phenotype, or are you going to find the cognitive impairment resulting from the psychiatric disorders and all the medication? And then you also find, it didn't perform well in school, couldn't be schooled, couldn't work independently. You don't have well-tested individuals in this. There are exceptions. I don't debate this. So no quotes here. You know who you are. Test your patients, please. Which leads us to a question I've been avoiding so far. Is how do you test the patient? And there is no established typical myopathy program for cognitive testing. You can go to the literature and look what people have done in the disease you're looking at or you're suspecting. But if you look through all the literature, actually the Montreal Cognitive Assessment, the MOCAR, is used pretty often. And if that is kind of sketchy, then dig in, try to figure out what this is. You can see from the various items which direction you're going with this patient, and then you got to talk to your neuropsychologist probably for proper testing. But please try and do this, and don't say, well, he wasn't well cognitive. Yeah. Another awful issue. So nobody likes fatigue. And nobody likes fatigue patients, or most people don't like fatigue patients. Our patients don't like fatigue either. And it's a freaking complaint. And what is it? Is it a confounder? Is it a phenomenon? Is it a disease? It's really extremely hard to figure out. But it is the major road to those who have not inherited their myopathy, right? The inflammatory ones. And they got cognitive complaints. And you think, now what's this about? You don't have brain inflammation, do you? So this could be something. And research really is a problem here. There's this wonderful paper where they looked at a lot of citations on fatigue and cognition in chronic diseases. And they found 10 studies, 10 out of 1,800 that they could use. And in those 4 said there's a correlation between cognitive impairment and fatigue. So great study. What am I going to do with this result? If you talk about this, you got to start figuring out the nomenclature and see what people are onto. So the thing that we all talk about, fatigue, is also called experienced or subjective fatigue. And the typical complaint is you don't have the energy to start doing something. That's not the only complaint, but it's a typical complaint. And it's extremely common in myopathic conditions. So you can look at the paper, 60%, 70%, 80%. It's all over the place. And in particular, it's also in the non-hereditary myopathies. So it really is a problem. And then you've got fatigability, or what they call physiological fatigue. And this is just your body getting tired. If you're doing something at a certain level over a certain time, you're going to have to put in more effort. And after a while, you're not going to be able to keep it up. So this is, and actually muscle work is one of the easiest thing to look at this kind of physiological fatigue or fatigability. And it is also clear that this is as a central component and a peripheral component. The peripheral is muscle and the peripheral nerve, and the central component must be there because this is the motor system telling the peripheral system go, right? We need force here. And if you look at this, it's kind of immediately clear that in patients with muscle disorders, you're never ever gonna have somebody with just peripheral or just central fatigability. Because if you change the setting in the periphery, the central nervous system will have to change as well. Right? You're not having the same amount of muscle fibers on your activation because the motor unit has changed. You're not having the same response rate in falls because the nerve isn't conducting properly. You can't separate those two in a physiological function, but you can try and differentiate them in studies. And so let's go back to that other fatigue problem. So this is typically self-reported. It can't be measured from the outside, or it can't be measured well from the outside. If you're into neurophysiology or sensory physiology, look at fatigue studies. There some really brilliant studies. They're really funny ideas how to figure out whether somebody is fatigued or not. While of course the physiological fatigue is a lot more straightforward, but you still have complicated setups to differentiate the peripheral and the central component. And interestingly, in the few studies that report doing this, there's not such a big difference in fatigability between patients, neuromuscular patients, and healthy controls, which seems surprising. But mind you, this is going down from a level. This is not being on the same level, but it's the going down. So they kind of tire similarly. There's obviously no myasthenia patients in there. And but the initial measurements of one of the elements of central fatigability has a certain correlation to reported fatigue by questionnaires. This is a study that has been discussed on end in many, many papers. And it's really hard to know what to make out of this. One idea is that the brain kind of says, oops, the muscle isn't well. I have to be careful with this, which is an interesting idea. I'm not sure it works too well in my world where you know these things change. They're differently connected. The brain is also different in a number of those diseases, but it is an idea. The other idea, obviously, is that there is something telling the brain, go easy here. And this, of course, is the alchemist's stone. This is this thing that causes fatigue. And there are theories, but there's nothing proven. And you know that fatigue research is taking off now after COVID. And it's going to be really interesting. But it's also a dramatic problem because almost every patient who's coming to your outpatient clinic with a muscle disorder is going to have fatigue. And we don't know what to do about it. You know, is it okay to train them? Yes, it's probably okay to train them a bit. Should you give medication for that? Well, you can try, but what? Are you going to give things that drive them, or are you going to try and lower the pain threshold or increase the pain threshold, which might lead to injury if it's really something protecting the muscle? It's a tricky thing, and this already, oh, I'm not too fast. It already brings me to the end, which is we are not far in yet. We found immense amounts of data in not too few diseases in the myopathy field with cognitive problems, but we're not addressing them well so far, and we're not assessing them well so far, unless they are in some centers or some studies. And this is a problem. It's a logistical problem as well. If I couldn't test neurophysiological tests all my muscle patients. It's just there's no personnel, there's no time. So we will have to come up with something to grasp this thing and possibly to do something about this. And one of the studies that I'm talked about in the myotonic dystrophy type 1s, where they addressed these problems, they did online trainings, virtual reality stuff. Um, so it might be something that you can easily bring to the patient, but obviously you have to know what to bring to the patient and what to look for. And yeah, with that, I think my uh, co-researchers and contributors in this research it's a bit. I'm not doing cognitive research, but some of them do. Um, and Louisa particularly provided me with a wealth of literature, and you say, there got to be something about this. Please dig on, and she did. And of course, Marianne was the person who gave the first push for this. I'll try to answer questions now.
Thank you very much, Jens. A very interesting and diverse approach to a very complicated topic. We have a question on the chat from someone who left in the meantime, so I'm going to voice it. The question is about if tics are frequent in patients with dystrophinopathies.
I don't think they're frequent, but I've heard it reported. Yeah, well, the tic disorder actually goes in the psychiatric direction. So if you look at the Becker spectrum, yes, you could suggest that people there.
Okay, so I wanted also to ask myself about, I know that you've said frequently that you are an adult neurologist and probably you're not so much involved in those stages where teachers at school start asking about the support to deliver to patients like the ones you've described, and I would think probably about the Duchenne boys as a particular case. And what I would like you to tell us is, in your experience, in your view at least, how much does the testing of those patients modifies the kind of support that they receive? Or do you think that the support is basically dependent on what exists in the field and basically it's not going to change much regardless of the testing that you do? Because basically I think that we all want to test our patients as deeply and as thoroughly as possible, but at the same time we need also to be realistic in terms of what effort we do in terms of in relation to what we can deliver.
Yeah, well, I think in the school question is pretty much a critical one. as with patients with severe muscle disability will already have particular schooling, and they're going to be in one corner there. And in Duchenne or dystrophinopathies and in parts of the myotonic dystrophies, language problems are pretty frequent, and so this is going to affect learning. So language testing is obviously something that can easily be done in a school setting or a school psychologist setting, and is certainly important. Whether you really have to have the entire range for, well, it depends on your opportunities. Can you address it all? So if you find the strong points of the kids and find the weak points of the kids, you can kind of emulate your teaching schedule and efforts. So I think this is valuable. And I certainly think if people going into jobs or into secondary education are another critical part, because they always come and say, yeah, would you write me a letter saying I can do this job? And they all think about the physicality of it. They all think about muscle force. And so I think that's an interesting point as well, to say, well, um, this is a disease where we see a lot of attention deficits. Are you really going to be a flight coordinator? Should we do a test first? Yes.
Mm-hmm. Yeah. And the other thing that you've mentioned, and is quite interesting, is the effect of exercise on fatigue. And I would even ask myself and yourself the effect of exercise on cognition as well.
Yeah.
And as you know, there are a few examples in myotonic dystrophy, for instance, where tailored exercise combined with other techniques like CBT have been positive in terms of reducing the fatigue of patients. Do you think that we could have the same effect on cognition, either in that disease or in others of the spectrum that you've just mentioned?
Well, it's hard to speculate what will work for a certain disease, but yes, I think you get an effect. I think you get an effect that goes beyond the metabolic workings of the muscles. Um, I think you can address social cognition very well with that, and after that you come into sports science, and obviously this is going to be extremely different for people with muscle diseases. But I, all the studies that I know of, where people try to have adapted exercises for myopathies, they didn't do any damage, and they did a whole lot of good. I just have to say there's not much cognitive data to go on. And then if you look at cognition in sports, then you find things like alertness, and people who go to long distance runners or sprinters, and have them test at certain amounts of effort, and look whether the arousal there has an effect. Oh, I'm not sure we can do this in muscle patients. So should we expect this to happen? But I'm sure there will be effects as well.
Excellent. So there is someone. I'm Nirvan Nandi. I'm going to unmute you so that you can voice your question. If you have any difficulties in talking, I can read it. Anirban?
Yes, can you hear me now?
Yes, I can hear you.
Yes.
Yes, that's great. But my question to you is, do you also find sporadic myopathic patients? Does they also have cognitive declines, or do you regularly would like to send them to a neuropsychiatric evaluation, or how, or is it with, or it is more oftenly we see in congenital myopathies? Thank you.
Well, it's a totally mixed field. Like in congenital myopathy with Nemaline rods, there are few cases, so nothing there. And in others, like the alpha dystroglycanopathies, you run a high risk. So this is obviously, I can't pin that down. But looking at sporadic cases and the cases of well, where you don't really understand how the brain should be affected. There are surveys of patients, and there is a survey of patients with inflammatory myopathies and fatigue and cognition affection, so reduced cognition, is always in the top 10 of the complaints of the patients. So it's in their experience, it's there. And yes, I would love to have them tested, but I don't have the capacity for that. And there's also something that I didn't put in here. There's an old abstract about McArdle's disease. So a metabolic condition that doesn't really reach the brain, where they say they've got cognitive findings in testing them. Again, it's a case control. And if you look at the readout of the McArdle registry, I think it was more than 80% that said forgetting things was one of the symptoms that they associated with the disease. Now, it's the myophosphorylase. It's not in the brain. What is the problem? Is it the pain? Is it checking your watch about your heart frequency? I don't know. But yes, I would love to test these people. But obviously, it's going to be the most difficult terrain of all.
I absolutely agree with you. Thank you so much. Because as you mentioned, I had one patient with a sporadic onset Nemaline myopathy, and but she was so asymptomatic for long time, and once I thought to send her just to be sure she's not. She doesn't have any cognitive decline, but I got a strange result from our neuropsychiatrist that she's very much into cognitive, where her MMSE was around 26 or 25, which I actually didn't expect it at all.
Yes, they could all be double troubles, but they can't be all double troubles.
Thank you so much for your answer. Thank you.
And now to end, we have Dr. Josep Gamés. You can unmute yourself, Dr. Gamés, or I can read your question as you like. So it seems that probably he doesn't have the possibility of
still muted, yeah.
So with what frequency do you recommend examining neuropsychological tests in young people with myotonic dystrophy type 1?
Ooh. There are actually recommendations in the literature, and they run pretty frequently. So they usually in the studies they do a year or 1.5 years, but then again those are studies. So you don't want your studies to go for forever. And I would go with the problem again, in schooling and these kind of things. And in the congenital myotonic dystrophy type 1, you're gonna see a lot of neurodevelopmental damage, so that shouldn't really progress. In myotonic dystrophy, as they grow up, whether there is progress or not is still up for debate. Most people believe there is a certain amount of progress, and so I wouldn't really do it every time people come back to the clinic. But if you've got an impression something's going on, if the patient says, yeah, well, I'd like to know, then I'd go back and do it. And obviously there are ranges that you can't, if you have less than 3 months between testings, people are just going to learn the tests, so they're going to get better. You need at least half a year, 9 months between tests anyway, so you'll end up somewhere above a year. I'm sorry, it's a sketchy answer.
Well, it's the possible one. So thank you very much, Jens. Very, very nice to have you in the beginning of this month dedicated to muscle diseases. And thank you to everybody who has attended. As usual, this recording will be then available through our website. and you can review it afterwards. And I hope that we all meet soon. Next week, there'll be another webinar dedicated to the muscle diseases. As I said, it's the month for the muscle disorders. Thank you, and bye, everybody.
Thank you. Bye-bye.